Hi everybody, good afternoon from San Francisco. We normally do our go live introductions of new HCMA recognized centers of excellence from my desk in New Jersey, and I use technology to talk to our partners around the country. But today I'm here at the university campus to bring you a brand new program with some faces that if you're from the East Coast, you might remember. So during this presentation, we're not going to be able to take questions and answers during this session. However, if you have questions for us at the HCMA or for the UCSF faculty, please post them below and we'll make sure that you get some answers to your questions, and we'll be happy to put you in touch with the right people. So without further ado, I am with the Doctors Abraham, who formerly were on the East Coast and are now here on the West Coast. So welcome to the HCMA page.
Thank you, Lisa.
It's a little bit different of a situation for us. We're like, who do we look at? Where do we talk? So we're going to address the people out there, and we're going to have a nice discussion about hypertrophic cardiomyopathy and how these fine people got involved in this work. So the first thing I like to ask physicians who care for hypertrophic cardiomyopathy patients is, when's the first time you heard about hypertrophic cardiomyopathy or even heard the term? And we'll do a ladies first.
Sure. So I first heard about hypertrophic cardiomyopathy during my second year of fellowship at the Mayo Clinic, and I believe it was either Dr. Rick Nishimura or Steve Allman who were talking about hypertrophic cardiomyopathy, and I got very interested in it because of the diverse presentation of the patients.
And you?
So again, it was at the Mayo Clinic, and a great place to learn about HCM. So I was an advanced fellow there doing a lot of imaging and mechanics of imaging, or imaging mechanics rather, and cardiac mechanics with imaging. And I thought hypertrophic cardiomyopathy was intriguing, and I heard the term there as well. I'd heard the term IHSS and all that even way before as a resident and an intern at other places. But this is where we saw enough that it became a topic of interest, and something that imaging could learn more about from the condition, and the patients with the condition could learn more or be evaluated better with sophisticated imaging. So that was my point of interest in HCM.
So a little bit out of order from what we discussed before, why don't you tell our viewers a little bit about your training and your background so they understand your interest levels and where that comes from. Again, ladies first.
So during my fellowship, I trained initially in basic electrophysiology and then in clinical electrophysiology. And my interest in hypertrophic cardiomyopathy was induced by this research that I was doing, where I was looking at the relationship between energetics and cardiac myocyte excitability, and essentially how energetics or energetic deficiency could lead to arrhythmias, and at the same time I got exposed to hypertrophic cardiomyopathy and this high risk of sudden cardiac death during exercise. At that time I thought that it's possible that it is energetic deficiency could be causing sudden cardiac death in HCM patients. That's what got me very interested in HCM, and I attended HCM clinics, and I learned more about HCM and decided I was going to devote my clinical as well as research interest to HCM.
That's a really interesting way of coming at it. It's, from the table, from the bench, to look at cardioenergetics before we really even knew the term cardioenergetics, and say, how is that a trigger potentially for arrhythmias? And that's work that you're still in the process of.
Absolutely, yes. I'm at the University of California at San Francisco. I've been focusing on looking at energetics in cardiac myocytes, both in models, that is cell models, in animal models, and in people. So we are developing, working on this new technology where you can actually image metabolism in people's hearts.
Wow. We'll have to talk more about that a little bit later. Ted?
So my interest again came from imaging. I'd done imaging prior to coming to the Mayo Clinic, and during my advanced imaging year, there was a new technique that just had been published in Europe saying that not using the human eye but using computational techniques, that you can actually look at the heart or examine the heart and look for very subtle differences in function. And HCM was intriguing because the function on the surface looks normal or even hypernormal. But it seems to me and to everybody else that if you have a myopathy, your function's probably not normal, but there was just no way of figuring that out. So this technique called strain or tissue Doppler or cardiac mechanics was a great technique to look at these folks who had functional problems but just not evident to the human eye. So that's how I started, and I felt that this condition was ripe for this because it looked normal on the surface. Everybody would say, oh, you're doing great. And part of the misdiagnosis of HCM was because of that, saying, your heart's awesome because it's got an EF of 75%, but EF was just not the right parameter. So that's how I got interested in HCM. And again, the Mayo Clinic, whether it's Rick Nishimura, Tajik, all the wonderful folks there taught me imaging, taught me to take care of patients, and it blended very well with my emerging and nascent interest in this new technology, which is not nascent anymore. It's 18 years old.
Yeah, it's been a while. So, yeah, Mayo Clinic is a fantastic incubator for great HCM thinking and logic, and we have a number of their progeny around the country doing HCM work all over the place, so that's great. So we know what has intrigued you. We know, don't worry about that. We know where you came from, but one of the most unique factors about this particular program is it is the only HCMA recognized center of excellence, and I would argue almost anywhere in the world. Well, no, we have one other program where there's a husband-wife team, but you are the only husband-wife co-directors of a program. So HCM is, unfortunately, in some ways, almost like for the patients. It's 24/7 for you guys, isn't it?
Absolutely. I actually even introduced my 9-year-old to HCM, and so she can pronounce the whole hypertrophic cardiomyopathy.
That's good. Maybe she's one of our next HCM researchers or clinicians. How long have you guys been married?
More years than we care to admit.
Okay, well, we're going to hope that it stays that way after this interview. So, you guys were on the East Coast. You were at Hopkins for many years. And now you're here. How long have you been here?
1.5 years since we moved. We moved last summer.
Okay.
Well, the summer of 2017. And so we've been here 1.5 years, almost 2 years in August.
Okay, and other than the ocean being on the opposite side, what's different about being on this side of the country? Anything? Patients?
I think the most important thing is great institutional support at UCSF for the HCM, both clinical program and the research program. And so in a very short period of time, we've been able to accomplish a lot thanks to support from our leadership.
That's fantastic. Without good institutional support, programs can't flourish. And I'm really glad that you have that here. So when we're talking about programs flourishing in research and clinical, your co-directors, how does that break down? Who's doing research, who's seeing patients, or is it a little of both for both?
So we both see patients, but we have different focus. So Ted is more interested in mechanics, and so he sees patients with obstruction. And I'm more interested in the arrhythmia aspect as well as microvascular dysfunction. And so I see patients who have any arrhythmias, heart failure, or angina, essentially complex patients with a lot of different issues.
And do you share patients and consult on each other's patients?
Absolutely. So Ted does all the he reads all the echoes, and so he provides a really good understanding of patient's physiology, which then helps me tailor care and figure out what therapeutic regimen each patient needs. Because there's no one-size-fits-all in HCM. I think the key with HCM is a very deep, what we call deep phenotyping, or understanding what the cardiac physiology is and what is contributing to the symptoms, and then figuring out what the best therapy is for that particular patient.
So the patient actually here gets the benefit of 2-for-1. It's a 2-for-1 deal because on the intake, sometimes it's difficult to figure out who's better served with which of the two physicians in the HCM clinic. So if a patient comes in, has a lot of heart failure, a lot of angina, or lots of arrhythmias, we just saw a patient who has had seven discharges of his ICD. Oh. And so that although I saw the patient first, And once I did the full imaging, I said, you're better served by seeing Roselle. And if it's more of an obstruction or a mechanic issue, and I see all the echoes, and we sort of discuss them sometimes going back home, talk about patients, say, okay, what should we do next? So we have this ongoing consultation, and the patient, I think, gets the best of both worlds, which is two people with a common interest but a very different spectrum of specialty. Mine is mainly imaging and physiology and hemodynamics and cardiac mechanics, and Roselle uses all her basic science knowledge and clinical expertise in angina, heart failure, and arrhythmias. You know, she's a clinically trained electrophysiologist from the Mayo Clinic, and uses that to cover those aspects. So the patients get the benefit of both.
I find that she always underestimates or expresses the EP background. She's like, yeah, I'm an electrophysiologist too. That's kind of a big deal. There aren't a lot of women electrophysiologists, and we could wear that badge more proudly. We got to get out there and promote that.
And to your previous question, I mean, I completely echo what Roselle said, is we had a great experience on the East Coast. We learned a lot, saw a huge number of patients, and developed the expertise that serves us very well. But here, you know, the West Coast is the best coast. Oh! But so other than that, UCSF truly, you know, whether it's Jeff Olgen, the director of cardiology, or just the people around us, you know, someone like Peggy. The amount of support that came in and really wants this program to succeed. I think the true beneficiaries of this are the patients with HCM and their families. And we're so thrilled to be part of that effort and the family.
And just to add on to that, I think we have gotten a lot of other people also interested in HCM at UCSF. We have fellows who are interested in HCM, and we have now several faculty in radiology who are all working on HCM. So on molecular imaging in HCM patients, and so HCM has gotten a lot of people have been interested, have gotten to know more about HCM, and are committed to studying HCM patients
and basic
doing
scientists.
research.
Everybody. It takes a village. Sometimes the village is just an awesome city on the West Coast.
Okay, there we go again with another knock to the East Coast for the Jersey girl. So we have to go back and do a little history lesson here, and I'm going to let Roselle tell the story, and then I'll jump in here. But I've known you guys since before your HCM days, a little after training and looking for that, where shall we go next? And I was at the American AHA conference, and HCMA had a booth, and this woman comes over and starts going, oh, hypertrophic cardiomyopathy, and number one, saying it correctly, and number two, very excited about it. So, of course, that makes me excited. And then what happened?
Yeah, so that was my first AHA conference. I think it was during my last year of fellowship, I believe, or just after I moved to Baltimore. And I had my undergrad student with me, and so he hadn't heard about HCM, but I said, that's this amazing disease, and we were both working on optical mapping of arrhythmias, and I said, we need to go and check out this booth that says HCMA, and I had never heard of HCMA, and then I met Lisa, and I was really impressed, and I told Lisa, we really want to start an HCM program at Hopkins. Can you support it?
I said they need some organization, and let's see what happens. And that was, 15 years you were, or 15? Yeah, 15 years.
And then Ted moved from Mayo to Hopkins, and that was what was needed for the program to be started, because I did not have the echo expertise to set up a program. And so Ted started the program, and he worked on HCM on his own with very little support for almost 5 years, I think, to build up the HCM program at Hopkins.
Right.
Yeah, no, I remember Roselle coming back from AHA and saying, and I still hadn't moved. She said, when you move in the next 6 months or sooner, the first thing you need to do is set up I met this wonderful lady at HCMA. She's actually a patient herself, and she's going to help us, and this is what we need to do, is set up a center here. And I said, oh, yeah, well, we've got lots of people coming and saying these things. So when I went there, she said, no, we have to do this. And so I said, okay, we were both interested in HCM anyway. Let's set up a center. And then, of course, you helped us set up the center there. And I don't know if you've helped the same people set up a center in 2 different parts of the country. That might be a first as well.
That is a first. I have helped with the satellite program and the original program, but not a bi-coastal relocation.
Right.
So this is a first for the HCMA too.
So you do HCM relocation as well?
Yeah, maybe. I don't know that I want to do that too much. It's a little complicated.
No, yeah.
But we do have a couple of other people moving from one center to another right now. There's a little transition going on. So I'm getting a little bit more experience in there. But for their institutions, like your old institution, they may lose you, but the HCM community gets to keep you. And we keep you in our system, so people can, if they're on the East Coast and they really developed a relationship and they want to continue care, we could do that. It's just a longer commute. But I've had people travel quite distances to see particular doctors. So we know how long you've been there. So let's talk about research a little bit, because I know you both have research interests. I'm going to turn it around and let Ted start on this one.
Sure. As I said, my interest is in mechanics, how the heart moves and how each segment of the heart moves, how it does so at rest in response to exercise. We know that most HCM people are feeling just fine sitting down or having their dinner or watching TV. It's really when they get up to walk or to do something they love, hiking, jogging, swimming, that's when they feel their symptoms. And we've always found, and because people thought the EF is normal, so there's another reason for them to have symptoms, our take has always been that the heart muscle itself is still suffering. The heart muscle still is at risk and has a problem. And we now have techniques that we've had for the last decade and a half, techniques that look at that. So the last 14 or 15 years of my life has been spent looking at the muscle itself. And, we've been pushing this concept that we should not ignore people who don't have obstruction, because now I just heard, I was 2 weeks ago from someone who's done a very large study that they're finding the same findings we're finding, which whether it's patients or frankly even the community has difficulty accepting. And I understand it's so counterintuitive and paradigm changing that you really need to make sure it works. And we've had, experience in several patients. So to me, that's of interest in figuring out if the myopathy is bad, how does that inform on how well they do, how at risk they are for heart failure, for angina, for cardiac arrhythmias, even for sudden cardiac death. And if the myopathy is so bad, will that inform on how they respond to medicines? Okay, you get a medicine, the one that improves your myopathy may be the one you prefer versus something else that makes you feel equally better but doesn't help your heart muscle, because that's the part that we can't see visually, that the standard echo can't see, and there's so much hidden beyond what the eye can see. So to me, that's been a great ride and continues to be one.
So I'm going to dive into that one for a minute and kind of hit it from hypothesis type perspective. So we have patients watching, we have clinicians, researchers, industry watching. You just said some really heady stuff there. But let's talk about energetics and muscle. So if somebody has been diagnosed with HCM and they feel fine, and those are my air quotes with one hand, because we think we're fine, but you're looking at the muscle and saying that muscle's not fine. How much of a problem do you think it is that there's a disconnect between recognition and understanding of symptoms, what's normal and not normal, and the problem that the clinicians have saying the muscle doesn't look that bad from the imaging that we're able to get at this time, either echo or MRI. How much of a burden do we have to try to bring those two together, diagnosing and really quantifying burden of disease over this muscle that is wonky now, might get a lot worse later, or might just kind of stay a little wonky?
Though that's not only insightful, I think this is frontiership in HCM, and I think you've hit the nail on the head, which is the difficulty among patients and frankly among all of us clinicians to bridge those two has been the big part. And what is the true burden? You use the right, sort of the most accurate term, which is what is the burden of the disease? The burden of the disease is what the heart is feeling as far as its overall weakness. And until we quantify that, we've shown, for example, in 900 patients that walking in the door, if your strain is below 10%, you have a 4.5 times the risk of someone whose strain is 16%. So walking in the door, that's your risk. doing nothing else, not
Risk
even asking them
of?
a single risk of either heart failure, death, arrhythmias, or stroke,
Even stroke.
even stroke.
So,
Wow.
so I think just to maybe perhaps explain this a little bit.
Please.
I think the other thing that we do routinely is the stress test, and so the exercise stress test. So as a result, we're able to integrate the patient's functional capacity. What happens to the EKG, what happens to the echo, what happens to strain, both at rest and with stress, with the patient's functional capacity. And so you can have patients who perhaps are in denial and who have gradually reduced their exercise capacity and who say, I'm fine. But when you exercise, we know for sure how fine you are. And so Ted has set up this protocol where we routinely do exercise stress testing in most of our patients, unless you have an orthopedic problem and you can't really
Right.
walk. But short of that, the majority of our patients have stress tests, and we not only look at the muscle or what happens to gradients, but we can also look at chronotropic response, which is another very important
Explain that
aspect.
for patients.
Yeah, so it is the response of the heart, is the heart rate response to exercise. I've had several patients refer to me who are very short of breath and very fatigued. And their main problem was not that their heart muscle was very weak, but it was just that their heart rate wasn't going up enough for them to be able to exercise. Because when you exercise, you need to have an increase in cardiac output. And your cardiac output is a product of stroke volume, which is the amount of blood that the heart can pump with each beat, and the heart rate. And so in hypertrophic cardiomyopathy, there's a limited amount that your stroke volume can increase because the heart is thick and it's also stiff, and so the cavity size is smaller, and so the heart rate has to go up. And if the heart rate doesn't go up, either because the sinus node is remodeled from the disease, it's called electrophysiologic remodeling, or because of medications like beta blockers or calcium channel blockers like verapamil, which can slow your heart rate a lot. And so that can also give patients problems of fatigue or exercise intolerance. And so there are several possible causes, and so we have a very comprehensive evaluation of patients right at the first visit so that we can understand what is going on, both from a pumping standpoint. So I explain to patients that there's 3 different issues. One is the architecture, one is the plumbing, and one is the electrical. And that there are 3 different issues which are related, but they can do different things in hypertrophic cardiomyopathy. And so I think that helps patients understand a little better what is AFib versus sudden death versus microvascular dysfunction and angina versus obstruction. And I use Google Images to explain to patients exactly.
So my
what
talk
is
on
going
that is the heart is a house.
Yeah.
Yeah,
They have
exactly.
rooms, they have hallways, they have doors,
Exactly.
they have plumbing and electricity, and
And the exit ramp to the highway. So I always explain the LVOT is the exit ramp to
ramp.
the highway, and you've gone from 3 lanes to 2 lanes or 1 lane. And so if you're down to 1 lane, you probably need a myectomy or septal ablation. And if you're 2 lanes, you may respond to meds.
But to your point about stress testing, the guidelines say, for example, if your gradient is more than 30, you shouldn't be stress tested. So we looked at 1,000 stress tests and found that number 1, it's safe. Number 2, in these folks, it offered so much additional information. And others have also published on stress testing in general, but we focused on making sure we included a fair number of people. At least 1/3 of our 1,000 stress tests were done in patients with significantly high gradients. And they didn't have they were not dropping dead on the treadmill.
No.
And we got so much more information. And many patients, we convinced them that they're actually not doing as well as they thought they were doing, to results points and your point saying they slow themselves down.
Right.
And say, I'm feeling fine. Can you walk? Of course. But then when you walk on the treadmill, they could barely do a minute. And that convinced them that there was really something wrong with them.
And then also response to therapy. You have patients who have walked just 3 or 4 minutes, and then they walk 7 minutes the next time. And it's very encouraging to the patients, too, when they see that not only do they feel better,
right.
but they also can exercise longer in an objective test.
You brought something up earlier that is a point that comes up to me when I'm talking to people who are going to a new center. A lot of people are worried that they're just going to go in and they're going to give me more medicine. And I try to explain to people that we might get you off of some meds and put you on better meds or even lower doses, depending upon what it is that your heart needs now. And what you needed 10 years ago may no longer be what you need today. So going to a center of excellence where you understand the really small nuances that can be HCM, you might actually lower your dosing. and you may find out that there are new medications that might be available. So we asked you about research. You gave us an answer. Roselle chimed in. Was there anything else you want to talk about research?
Yes. So since I moved to UCSF, I've set up this really big research program that includes both clinical research, translation research, and basic research.
Wow.
And there's three main areas. So one is arrhythmia risk stratification. The second area is microvascular dysfunction, and the third area is metabolism, energetics, and personalized therapies for patients and their families. So let me just go through all three areas.
Those are lofty.
Yeah.
Go for it.
And so so I've been working on this for several years, and it was just here that I was able to actually put everything together and have the support to be able to establish the program. And so starting with the arrhythmia. So what I believe is that it's great that we have these guidelines, but it's still really difficult when you see a patient, to figure out what their risk is, especially when they're not when they're not really convinced that they want a defibrillator, or they just are shocked that you're telling them that they could fall, die suddenly. And I think it would be helpful to have sort of a better understanding of what the heart is. So we use a lot of historic factors in the risk in the prediction of sudden cardiac death, like family history, which are very important. But I think in addition to them, it would be helpful for us to actually understand what the heart is going through. Is there any electrical remodeling in the heart? And so you add these features to what's already known to have a better idea of who's at a higher risk.
So hopefully the identification of new risk markers.
Exactly. And so in order to do that, we are doing a combination of multimodality imaging and combining that with machine learning. Because with machine learning, you can take it's hypothesis generating. You don't need to know ahead of time. The machine, the model identifies, and so
where the trends are.
Exactly. And the good thing about machine learning is the model can be updated as more information is available. And so I think the future really for prediction, and I think atrial fibrillation is also very important, because people can have atrial fibrillation, can have stroke without AFib, and I've had several patients who email me and said, "Oh, I had a stroke, but I've been monitored every year, and I've never had AFib, and I've never had palpitations." And so it's possible that you may have AFib a stroke in the absence of AFib because of a significant myopathy.
Right.
And so I'm looking at both AFib as well as ventricular arrhythmias with this approach, which is a different approach, using a combination of multimodality imaging with machine learning, both of EKG data as well as of EHR and imaging data, to predict arrhythmia. So that's more a clinical project. Microvascular dysfunction in angina is a big deal.
For the patients, break down microvascular dysfunction.
Yes, so a significant proportion of hypertrophic cardiomyopathy patients will present with chest pain, significant chest pain, in the absence of blockages in their coronary arteries. And at Hopkins, we did PET scans in them, and we found that the large vessels were fine, but the small vessels weren't working well, and as a result, large areas of the heart has less blood flow. And so I think that is a big issue, and we really don't know the mechanisms. And so in order to treat something, it would be useful, or prevent something, it would be useful to know the mechanisms.
True.
But we do know that this is a big problem, and so I think that is one area that I'm very interested in working on. And the third area is the energetics, because it's my hypothesis that one of the main reasons for sudden cardiac death is, especially during exercise, is that you have a very high energetic demand during exercise, and when you already have a heart that has an sort of an energetic inefficiency, then that could put you at risk for sudden cardiac death. And so what we are doing is we have methods now to understand what is going on with energetics, both at a cellular level, where we have cell lines derived from patients, so cell lines from HCM patients, as well as mouse models, and now we have, in collaboration with our radiology colleagues, we have the ability to image metabolism in people, and so our goal is to be able to characterize better what's going on at a cellular or molecular level in patients without doing a biopsy, using a combination of imaging, machine learning, and basic science.
So biomarkers on top of...
Exactly, biomarkers also.
So we're putting all of that together and hopefully coming up with an answer that explains the symptoms. We have a large number of patients that I've spoken to over the years who are not obstructed, who have recurrent chest pain. We steal therapies from other diseases. Renexa is one that seems to work, but in very high doses. But it's thought that something's going on in that microvascular level, those teensy little veins that bring blood to the heart muscle itself. Are we just too hypertrophied and we're closing them off? Is it a mechanical problem, or is it something different?
Actually, we've had pretty good success with treating patients with microvascular dysfunction. I recently had a patient who said she was really limited, and now she's able to run for the bus and chase her kids. So yes, it's all about sort of doing a very detailed phenotyping or understanding what the cardiac physiology is, and then figuring out what are the possible mechanisms, and it's not experimental medications, it's just regular cardiac medications that can be used in different combinations to treat patients with angina who don't have obstructive CAD.
So there's some new drugs coming to market, some new classes of drugs. Any thoughts on this concept?
So I think it's really great that we have these new. At least I've been exposed to one drug, which is mavacamten, and I think it's terrific. If it can reduce obstruction and reduce the need for surgery or ablation, so we're really looking forward to it. I think the key is to be able to find the ideal group of patients to test it on. So I believe in HCM is that. Very often we do studies in mouse models and we found something that works really well in mice, and then when we translate it into people it often doesn't work. It's not that the drug doesn't work in people and only works in mice. At least my hypothesis is that the mechanism or the pathophysiology of HCM is variable, and that if you can identify the correct patient population for that drug, I think the drugs would work very well.
True personalized medicine.
Exactly. So I think
the right patient with the right medicine
at the right time.
At the right time.
I think precisely. I think the timing is very important because at least based on our basic science studies, our studies in mouse models, the timing really changes, and so the cardiac physiology can change over time, and in patients it changes a lot too. So I think there's a lot to learn, but the bottom line is, I think we need to have a more individualized approach to therapies in hypertrophic cardiomyopathy.
I think that's right. I mean, there's a number of different pathways and silos that people can fall into, and that kind of segues to my next question. Research is really cool, and it's where we're going to be going, but clinical care today. Patient shows up and has symptoms that are confounding or confusing. What are where are your clinical challenges now? Where do you think we need to be focusing more on clinical care and understanding better?
I think angina and heart failure are the two big ones, because the obstruction, it's a mechanical problem that has certain mechanical solutions, and now with drugs like mavacamten has a backup medical solution. But the folks that are symptomatic and have no obstruction, there's really not much option. So I think those are the folks who could be as many as a third or more of the total HCM population. I think that's an area that I know Roselle's focusing a lot of research, but that's an area that we would need to look more deeply at and try to figure out a way to make them feel better and live longer.
Yeah, that's a little challenging group, which I used to be a member of. And I encourage every doctor I have a conversation with now, and I know I've discussed this with you guys, I was reluctant to do a right heart cath. Mm-hmm. I was not obstructed. I didn't feel great, but I was fine. And by the time I did my first right heart cath, my numbers were abysmal, and I almost didn't have time to get to transplant. Mm-hmm. So how do we get in front of this when the burden of disease is still a bit elusive? Mm-hmm. And that's, I think, a challenge for the HCM community. How do we better communicate with our caregivers And how do our caregivers take that information and process it into a clinical pathway that makes sense for that individual patient at that time?
No, I think you raise a very important point about preempting the disease rather than waiting till it's too late or you're really right at the brink. And on the right heart cath, we're fortunate to be in this group here where, one, we do cardiopulmonary stress testing on a fair proportion of patients, so we know before they get symptomatic that there's issues
Something's
there.
happening.
And the other thing is we collaborate. Our heart failure HCM heart failure group is led by Teresa DeMarco, who is a huge fan of invasive right heart caths. So anybody, even if they're borderline, they're getting right heart caths at a significantly higher rate than we were used to. So a lot of my patients, I was surprised at how high their pulmonary pressures were. Remember, echo is a great tool, but it's not everything, and sometimes you need to go to the gold standard. And if you're dealing with a special patient population, to your point, you have to get there quickly and not hesitate to wait till something changes drastically to do that.
So I think to that point, this invasive testing is very useful for two reasons. One is sometimes you have patients whose gradients are underestimated by echo, and I can say I have had at least 10 patients with that, who were very symptomatic, whose symptoms were disproportionate to the echo results or the echo findings. And in those patients, I would do both a left heart cath as well as a right heart cath. And my threshold is not very high for that, and that the reason being is that we can then do invasive gradients. And so if there ever is a discrepancy and I'm unable to get the I always tell patients my goal is to give you as high a quality of life as you'd like, and so if I'm unable to make progress, then I go very quickly to invasive testing because I want to make sure, one, that they don't have obstruction, because there's no underestimation of gradients by echo, which can happen. And two, I'd like to know what's going on with their cardiac output, cardiac index, as well as pulmonary pressures. And so I think symptomatic patients in whom I'm unable to make a significant improvement in their functional status, I go for invasive testing.
I think what you both brought up is excellent points. What I'm seeing more of is, because we as an HCM community and you as HCM clinicians are doing such a great job treating us, more of us are going to transplant because we're managed better and our heart failure isn't surprising everybody. We're catching it in time. I'm actually in communication with somebody who's created a non-invasive right heart cath. So we'll talk about that some other time, which will be fun. So we've been talking for a while now. I think our audience will have an understanding of the complexity of this program and the reach of this program, and that now, and I'm going to cough again, still getting over that flu, we now have a better care option for people in Northern California and people traveling into the San Francisco area. We've been partners with Stanford for a long time, but healthcare systems are complicated, and we need to make sure everybody has access. And here you see Medi-Cal patients, which there are a lot of Medi-Cal patients with HCM. I work with a lot of them. So we're happy to have a place for them to call home. And we also had a preliminary meeting this morning about a support group, and we're going to have a Bay Area HCMA support group forming very soon.
Fantastic.
Excuse me. So, is there anything else you'd like to discuss?
Well, I just want to say thanks to you. You've been an inspiration to our careers as HCM people, obviously.
Going to grab a water.
And thanks to you, we've now successfully set up 2 major centers.
Yes.
And again, you've not only served as an inspiration, but a teacher, an expert,
a
supporter, a well-wisher, a catalyst. So I commend you for the investment you've put, really devoted your life to this condition. It's a source of grace and inspiration. This is why we do things, is because you're there, and we are. You're not only an awesome partner, but a great leader of the community. So we appreciate all that you have done, but also not to the community itself, but to the two of us in our own careers as HCM specialists. You've made us more passionate about treating HCM patients, and we're delighted to be here, and congratulations on forming the support group. And yes, University of California takes all insurances and the uninsured, so we're very happy and delighted that we can offer this level of care to the community. And we're delighted to be part of that community.
And the other thing I like about Lisa is that I like the feedback. So you know, it makes if something doesn't go well, you're prompt in providing feedback. And I think it's important because that helps us get better and provide better care to patients. And that's been my experience, and I think, you know, you should keep going with that because that's finally, you know, the feedback is really important. And I think you're not bashful about providing feedback, which is great.
No, I've never been accused of being bashful once in my life. That is true.
And so we greatly appreciate it, and I think, you know, that makes.
Well, I think what's critical to kind of say there, and thank you for the compliments and thank you for the kind words. But it's my kitchen table startup. I'm a founder. You own that. But the organization has grown so much. We have a very engaged board now. We have amazing volunteer patients. We have partners literally all over the world now. Somebody calls me up. I need somebody in, you know, southern India to take care of my cousin. I gotcha. You need somebody in Florence. I gotcha. Toronto. I gotcha. Netherlands. We gotcha.
China. Do you have somebody in China?
Yeah, that's the one place I'm having a little trouble with right now. So why do you bring that one up?
Yeah. Today I just had a patient whose brother probably has it.
I have a 2 degrees of separation. I can find you somebody there. But we're growing a global community. So let's talk numbers real quickly. We know the 1 in 500 number that we use for HCM for a long time. Which would mean that you've got probably about 18,000 people in your area here at that number.
Correct.
But that number's not right because that's echo data driven. So then we add MRI, and then we add genetics, which we really haven't even talked about here today, but I know we're all big supporters of genetic screening in families with HCM. So we have the genetics. So we're somewhere between 1 in 2 and 1 in 300 if I had to make a really good guess. That means there's 1 million people in the United States alone. I was in meetings earlier this week, and insurance data is showing that we only have 150,000 people in care for HCM right now in the United States.
Wow.
We have maybe 15% identified. I don't believe we'll ever get to 100% because some are going to be subclinical. But I think there is this amazing growth opportunity here to identify this patient population, to organize and to mobilize this patient population. And that mobilization only can work when there's a good center to take care of these patients in a particular region so they don't get ignored, discouraged, and fall off of healthcare altogether.
Absolutely.
And if we work together as a community, and we have some amazing people in our community, some of the most brilliant minds in cardiology and in medicine. I mean, we can start at the very top. Eugene Brunwell made the first diagnosis of HCM. Don't get much bigger than that, do we? So we've got some real pioneers. But I think in a few more years, when people look back and say, where did, you know, really critical change come? It's because we take the time to get the bench work to the clinical, do true translational medicine, and we work as a community, a team, and we all work for the patients.
Absolutely. I think that's very well said, and that's really what drives us. And I think you're the glue that, for HCM, you're the glue and the diesel.
And the cattle prod holder.
Right. That pushes us and gets us along this way.
And you know, one of the other things that really got me even more committed to HCM was when I had these patients at the Mayo Clinic. You know, these grandfathers would say, "Can't you do something to figure out whether my grandkid will develop HCM?" And so that has been a very important area for me. Preclinical detection of HCM in patients with known and in families with known and unknown mutations. And so I think that's very important. And I still remember those in conversations I had, and that's a driver for the kind of imaging research I'm doing for this same thing. How do you do preclinical detection, try to find the molecular changes before they produce actual anatomic changes in patients with known and unknown families with known and unknown mutations.
We're about to launch a project with one of our partners to take those who've been genetically tested, 2 or more family members associated with a diagnosis, but no gene found, and we're going to do full exomes on them.
Excellent. That's
and that's, I think, where we're going to come up with some more discovery. So we're a bit of a unique model at the HCMA. We want research partners. We want to drive research. And then we, kind of set you up on something and we run away and then we come back and say how to come out, which is really easy for us and really hard for you. So we do appreciate the research work that you're doing and the clinical work that you're doing and the fact that your poor daughter probably is going to know more about hypertrophic cardiomyopathy by the time she enters high school than those PhDs know. So, that happened to another family. The name was Marin. It turned out to be a good story. Marty knew that. And although my daughter, our secret word when she was like 3 years old to make sure, you could get picked up by this person. At 3, she knew how to say hypertrophic cardiomyopathy.
Oh, that's a good one.
That's a good one. Nobody would pick that one up. That was the code word. She's 23 now, so don't try to use it on her. It doesn't work. So I think we're going to wrap up here, and I thank you so much for your time today. This is a lot more fun than doing it over a computer screen, so thanks for having me here at UCSF.
Thank you for coming back, and again for giving us the opportunity to continue our work in HCM.
Looking forward to working with you guys. So thank you all, and if you have any questions or comments after this presentation, please leave them in the comments below, and if you need to contact the HCMA office, you can get us at our office number at 973-983-7429 or email us at support@4hcm.org. Thank you, everybody. Have a great day.
Thanks,
Thank you.
Lisa.